Welcome to Chapter 12, Motor Speech Disorders. We'll start off with going over once again, like we did in a previous chapter, I think it was the stuttering chapter, about speech being one of the most impressive motor movements because of the rapid coordination of several different movements to produce even one sound. We can produce 8 to 12 speech sounds per second, which is pretty impressive if you break it down and think about it. We just kind of take it for granted that we can produce speech sounds that proficiently. Motor speech disorders can be an impairment of speech production caused by defects of the neuromuscular system, the motor control system, or both. Impairment of speech production with defects in the neuromuscular system would refer to a defect in the muscles made for speech, often found in dysarthrias. And then the motor control system would be the defects associated with apraxia of speech. And we'll look at both of those throughout this chapter. Defects in these underlying systems involved with planning, programming, and executing speech result in significant difficulties producing fluent, intelligible speech. Systems of speech production involve the respiratory system. Pulmonary mechanism is a major structure in the respiratory system, which regulates the inhalation and exhalation cycle for passive breathing and for producing speech. And the phonatory system. And the phonatory system regulates the production of voice and the prosodic or intonational aspects of speech. Then the resonatory system, which regulates the resonation or vibration of the airflow as it moves from the pharynx into the oral or nasal cavities. Resonance refers to the effect of the shape and size of the vocal tract on sound quality. And an important aspect of vocal resonance is whether the nasal cavity is used as a vibrating chamber or not. And then last, the articulatory system. This is the fourth system of speech, which regulates the control of the articulators within the oral cavity to manipulate the outgoing airflow in different ways, usually at very high speeds. Major structures involved in articulation are the lower jaw and lips for opening and closing movements and for creating constrictions at the end of the oral cavity. The tongue is also an important structure, and this creates constrictions and obstructions within the oral cavity. The tongue is probably the most important articulator because of its flexibility and capacity for high-speed motion. And these are just going over what I just talked about for each of the systems. Motor control refers to production of fluent speech requiring the rapid coordination of muscle activity across a wide range of muscle groups to maintain speed and fluency when speaking and to maintain accuracy of movements. The sequences of movements are programmed together as a single movement. Considering vast numbers of muscles and muscle groups involved in fluent articulation, you'll realize that there are a large number of degrees of freedom or the number of elements such as muscles that can be independently controlled. The magnitude of the challenge facing speakers becomes apparent. Motor planning, programming, and execution. Motor planning refers to the process that defines and sequences articulatory goals prior to their occurrence. Motor programming refers to the process responsible for establishing and preparing the flow of motor information across muscles for speech production and specifying the timing and force required for the movements. Then motor execution refers to the processes responsible for activating relevant muscles during the movements used in speech production. Sometimes it's difficult to take apart motor planning and motor programming. So motor planning and motor programming can be considered to be together for the purposes of learning about motor speech disorders in this chapter. Motor learning is the way in which practice or experience leads to relatively permanent changes in the capability for movement and is an important concept for understanding normal and disordered speech motor control. A schema theory suggests that individuals develop schemas, which are memory representations of relationships between various sources of information. Take, for instance, maybe a schema of making a bologna sandwich. You're going to learn after making a bologna sandwich more than one time. You're going to learn the schema for making that bologna sandwich. You're going to get out some bread. You might get out some mayonnaise. You might get out some mustard. Of course, you'll get out the bologna. Then depending on your taste, you might add lettuce or tomato to that bologna sandwich. And then you're going to put that bologna sandwich together and eventually eat it or give it to someone who will then eat it. So the schema becomes stronger with experience. The more you make the bologna sandwich, the easier it's going to be for you to do that, because you're going to store these store configurations in the makeup of the schema after every movement. And then for future movements, you can use that stored schema to produce the corresponding specifications that will lead to the desired outcome. In this case, a completed bologna sandwich. Prevalence and incidence. There are not very many studies specific to motor speech disorders. They're fairly rare, but there was a study done by the Mayo Clinic for acquired neurogenic communication disorders, and this specific study showed that for almost 60% of the communication disorders, 54% of the patients were diagnosed with dysarthria or muscle weakness, and 4% were diagnosed with apraxia of speech or motor programming difficulties. These types of speech delays affect about 4% of children. So it's a fairly low, they both are fairly low incidence disorders. The etiology, as we've talked about in previous chapters, or the cause. Motor speech disorders may be acquired or developmental. Acquired motor speech disorders result from damage to a previously intact nervous system, most often caused by cerebrovascular accidents or strokes, degenerative diseases, brain tumors, and traumatic brain injury. Developmental motor speech disorders, result from abnormal development of the nervous system or from brain damage to the nervous system in early development. Manifestation. Motor speech disorders are divided into impairments of motor planning and programming and impairments of motor execution. Motor planning and programming disorders are caused by an inability to group and sequence relevant muscles in order to plan or program a movement, and the motor execution disorders are caused by deficits or inefficiencies in basic physiological or movement characteristics of the musculature, such as muscle tone, movement speed, and movement range. Impairments of the speech motor system might also affect other oral motor behaviors, such as smiling or swallowing. The severity, according to the World Health Organization, sometimes it's known as WHO, WHO, distinguishes between 4 aspects of a disorder. And those 4 aspects are body structure, body function, activity and participation, and contextual factors. In body structure, this is referring to the underlying anatomical aspects of a condition that impedes performance. For motor speech disorders, the anatomical structure that is affected is the central and/or peripheral nervous system. Body function refers to the physiological and psychological functions that are disrupted in a disorder. For motor speech disorders, the function that is impaired is the ability to plan or execute speech movements. I'm looking at activity and participation. It's referring to the limitations that the affected body function has on performance and on a person's quality of life as defined by that person. Participation in life is indicated by how the speech impairment affects an individual's performance at home, at school, work, and or in the community. And then lastly, contextual factors include both personal factors such as attitudes, values, and coping strategies, as well as wider environmental factors such as the social support system and resources available to the person, the legal environment, and the social and cultural beliefs. Characterizing individual differences. As in the case with many abilities and disorders, a range of individual differences occurs for motor speech disorders. The effects of a neurological disease on an individual differ from person to person, even if the cause and severity of the disease are similar. Next, we'll look specifically at acquired apraxia of speech. This is an impairment of motor programming and planning that involves an inability to transform a linguistic representation into the appropriate coordinated movements. Specifically, childhood apraxia of speech is a phonetic motoric disorder of speech production. Children with childhood apraxia of speech, sometimes called CAS, are unable to translate linguistic or phonetic information concerning speech production into accurate motor behaviors, or are unable to learn the motor behaviors to execute planned speech. Sometimes I explain this to parents as their child having an idea of what they want to say in their brain. And then as those thoughts are channeled through pathways in the brain, they somehow become jumbled and come out of their mouth not as words the child intended to be saying from the thoughts that they had in their brain. Acquired dysarthria is a group of speech disorders caused by disturbances of neuromuscular control of the speech production systems. Defining characteristics include weak muscle tone, muscle strength, movement steadiness, movement speed, movement range, and movement coordination. Oftentimes, people with dysarthria, their speech is slow and slurred and fairly difficult to follow with what they're trying to say. Obviously, I was distorting my speech in that last sentence to give you sort of an idea of what someone with dysarthria might sound like. Different types of acquired dysarthria include spastic dysarthria, weakness and hypertonicity are two characteristics of that. Flaccid dysarthria, where weakness, atrophy, and atrophy will be present along with hypertonia, and hypokinetic dysarthria, where a slowness of movement, rigidity, and a static tremor may be present. Other types of acquired dysarthria include hyperkinetic dysarthria, where a person may have variable muscle tone, involuntary movements, and basal ganglia damage. Ataxic dysarthria, where the person will have cerebellum damage, incoordination, and tremors. And unilateral upper motor neuron dysarthria, where there'll be weakness on one side of the face, harsh sounding voice, reduced loudness. And then developmental dysarthria, be present at birth and usually accompanies a known disturbance to neuromuscular functioning, as might occur with anoxia during birth. Defining characteristics will be spastic dysarthria, dyskinetic dysarthria, or chorea, which means sudden, fast, or jerking movements, and athetosis, slow, writhing movements. All of those are defined pretty well in your book from pages 411 to 413, if you wanted to look more closely at those. And then we'll move to the assessment process. Professionals use a variety of measurement methods to evaluate motor speech disorders. Assessments should include measures of non-speech oral motor performance. Measurement methods might include, or professionals are going to use, perceptual, acoustic, and physiological measures to document motor speech disorders. Let me see, perceptual measures that I referred to a minute ago help the professional characterize the impact of the disorder on various aspects of speech, such as loudness, pitch, and breath support. These are crucial for differentiating motor speech disorders. And then acoustic measures involve a visual representation of the speech sound wave, sometimes via a spectrogram, and allow more detailed examination of speech abnormalities that may not be perceptible to the professional's eye and ear. And then the physiological measures provide quantitative data on aspects of the speech motor system, such as muscle strength, endurance, and airflow. Sometimes these measures involve simple equipment and tasks such as blowing through a straw in a glass of water to assess breath support. And then others might require more elaborate equipment such as video fluoroscopy to assess phonatory and resonatory systems. A referral and screening. Patients are generally referred for a motor speech assessment by healthcare professionals, typically a pediatrician for children or a family practitioner for adults. Then a screening of general motor speech performance is an important first step when people with suspected motor speech disorders are seen by a professional. After the referral is made, a comprehensive motor speech evaluation might be conducted following a screening showing that someone has a suspected motor speech disorder. So in the comprehensive motor speech evaluation, an assessment would include a motor control tasks that involve speech and non-speech movements. For respiration, motor speech disorders rarely result from isolated impairment of the respiratory system. However, when combined with impairments of other speech production systems, respiratory difficulties can undermine speech. Some of the symptoms might include short phrasings, reduced syllable repetitions, decreased speech rate, and uncontrolled phonation. Breathing may be irregular, shallow, or noisy, which may affect the rhythm, loudness, and rate of speech. Looking at phonation, the motor speech system assessment also involves careful study of the phonatory system. Some people with motor speech disorders will have phonation directly impaired because they have abnormal strength or control of the muscles in the larynx. Or phonation may be impaired as a result of deficits in other speech production systems, specifically respiration. In resonation, perceptual assessment will include watching the velum functioning during a sustained ah and looking for nasal emissions during production of oral sounds. For instance, the velum should be raised throughout production of a sentence like Bob took a cookie out of the box, meaning there should be no perception of nasality. One way to assess nasal airflow is by holding a small mirror under the nose during production of such sentences or prolonged vowels. Nasal airflow will fog up the mirror. Articulation. When examining the articulatory system, the clinician will study the stability of speech errors under different circumstances. If a motor speech disorder is the result of a basic physiological malfunction of the articulatory system, as in muscle paralysis and some dysarthrias, speech errors are likely to be consistent across repetitions, contexts, and tasks. Some of those might include repetition, reading, and spontaneous speech. And then looking at prosody, assessment of prosody examines the individual's prosodic variations in different types of language use, such as producing a declarative versus an interrogative sentence. This is new versus is this new, highlighting contrastive information. Like she likes the brown dog in response to the question, does she like the black dog? And indicating different emotional states, happy, angry, and surprised. And then following the assessment, a diagnosis will be next. And the professional will interpret findings to arrive at the speech diagnosis. Depending on the findings, a patient may receive a diagnosis of one of the various motor speech disorders discussed previously in this chapter. And differential diagnosis in motor speech disorders is important because the type of treatment depends on the nature of the disorder, and what might be effective for one disorder might not be effective for another type of disorder. For example, a focus on improving posture and breathing may be useful for patients who have a respiratory system impairment, but may not lead to improved speech for patients with aphasia or tongue paralysis. Next, we'll look at how motor speech disorders are treated. Individuals with motor speech disorders often have other clinical problems, such as aphasia, limb paralysis, hypertension, or a learning disability. Treatment goals will be to learn or relearn accurate production of speech. In doing that, be looking at motor learning, acquisition, and retention. So earlier we defined motor learning as the way in which practice or experience leads to relatively permanent changes in the capability for movement. And then next looking at generalization, which is another important goal of treatment. Application or transfer of a skill to related but untrained movement patterns. In addition to retention, treatment should aim to facilitate an individual's underlying capability for movement so that untrained tasks also improve. Two types of generalizations are response generalization, which brings improvements in untrained behaviors, for example, speech sounds. And secondly, stimulus generalization, which brings improvement in targeted behaviors in different contexts, tasks, and settings. For example, in conversational speech versus repetition tasks. Treatment targets. Clinical professionals carefully select treatment targets based on the nature of an individual's speech difficulties and the impact of the speech disorder on daily living function. Speech and non-speech tasks might be targeted in this. Activities might target oral motor exercises for tongue strength and range of motion. And then looking at simple versus complex tasks. Complexity or difficulty level of the target behavior should be considered in the selection of treatment targets. For instance, producing sounds intelligibly in a phrase, "I want some milk," is certainly more complex than producing sounds in isolation. Maybe for the word, to learn the word milk, to learn how to say the word milk. The goal of treatments for motor speech disorders is generally to improve the accuracy, stability, and intelligibility of speech and its naturalness or fluency. Two primary therapeutic strategies are to improve the impaired systems and to teach compensatory strategies. Obviously, if the systems can't be fully improved, then the compensatory strategies would be important to teach the person in order to have the best speech intelligibility that they can. And that is the end of the lecture for Chapter 12, Motor Speech Disorders. Thanks for listening.